Boa tarde. I have to move to English because it's the official language of the Congress. But thanks to AngioDynamics for having me here today. It's very good to be back in São Paulo. I did my residency at the University of São Paulo, just not too far from here, where I did my internal medicine residency, and I met and been together with many of you through a long journey until getting into medical oncology. I'm going to share with you the medical oncology perspective of a new modality, IRE. And this is something that we routinely discuss at our tumor boards. I have two champions on my right side here. I think both of them have been doing from the surgical side. I have worked with a group that did it predominantly percutaneously, either guided by CT or by echocardiogram. And now I am in another group that does it predominantly surgically. So I can tell you that I have seen the bad and the good from both worlds, and that is a lot of good to share with you. But my function here is to try to place the IRE in the setting of modalities that we currently have in the management of locally advanced pancreatic cancer. So I'm not a surgeon. The worst thing I could do here would be to discuss what is resectable and not resectable with you. You guys are going to kill me. But we can divide it in three major groups, and I'd like to concentrate, because that's the population of patients that we generally, most of the time discuss about using this modality in the borderline or unresectable population. And we are talking about 3/4 or more of the patients with pancreatic cancer that presented with metastatic disease, and only about 1/4 has locally advanced disease. The resectability criteria has been reported by the NCCN guidelines. It's kind of cumbersome to go through it. It requires a good surgical group and a good radiologic group to break it down, what is borderline resectable to what is locally advanced. But to make the long story short, when we have more than 100%, 180 degrees of an artery or a major vessel in the celiac circulation, we have a patient that is locally advanced. When he's less than 180 degrees, that's when we define as borderline resectable. And here you have an example of what is likely less than 180 degrees, and here what is more than 180 degrees. In that situation here, clearly unresectable. And here the cases that you guys strive to take care of, those patients that is straightforward resectable, and you take it to either a WIPO or subtotal pancreatectomy or distal pancreatectomy according to the location of the tumor. Now, many of us have been disappointed that even in patients with resectable disease, when you take them to surgery, unfortunately, in less than a year, most of those patients will have resectable relapsed disease, and that's really a pain. And then when we look about the interface and R0 resectability, you can see the outcome is better. However, when we have some sort of a plane between the tumor and in the portal vein, the hepatic artery, the superior mesenteric artery, and when we have an R1 resection rate, then the survival starts to drop. And the current paradigm on those patients, at least in the United States, is to prime these patients with a neoadjuvant approach when it's not clearly resectable with systemic chemotherapy. And that's what I do for a living. We made advances, although we're far from being good, we made advances in the systemic chemotherapy where we can actually, particularly in patients with borderline resectable disease, make a difference. But in addition to it, how can we incorporate a modality like IRE that can improve local control in the setting of the current management of pancreatic cancer? This was alluded by Dr. Wu here just prior to my presentation, the importance of laparoscopy in this disease. And even in the DNA age of fine slice CT with arterial venous phase, plus minus PET CT scan, we still lose about 1/3 of our patients with peritoneal seeding, despite of having, quote unquote, no evidence of metastatic disease on the best radiologic technique we have today. So clearly, and that's something that we did not do at the University of Miami, and they actually have pushed our series a little bit lower than we would have had if laparoscopy was done on a routine basis, is that we missed a lot of patients with peritoneal seeding because we didn't do laparoscopy in our patients. And that might be an edge that a surgical approach may have over a non-surgical approach in patients with locally advanced pancreatic cancer when IRE is indicated. Now, for borderline resectable disease, we are part of the Alliance, part of the MD Anderson group, and this is our paradigm. This is not based in randomized phase 3 trial. This is based on expert opinion. Unfortunately, we're still working on getting phase 3 data to better establish the sequence of approaches. But we generally favor in borderline resectable to go after the micrometastasis of systemic chemotherapy, and our preferred regimens is either nab-paclitaxel and gemcitabine, or a regimen that you probably heard of, because it can be very helpful in the selected patients that can tolerate it, then FOLFIRINOX. And then in those patients that do not present with metastatic disease, we then go for a local approach that is in general chemoradiation. In the centers that we have IRE, we kind of toss and discuss at our tumor boards, incorporate IRE to that. And then in the patient that become resectable, surgery is recommended. And here we switch. If the patient received FOLFIRINOX, would go for gemcitabine-based adjuvant therapy. If they received gemcitabine-based therapy in the neoadjuvant, we would consider 5-FU-based therapy in the adjuvant setting. Focus on locally advanced pancreatic cancer. Chemoradiation is still part of our platform. But again, here we like to prime with systemic chemotherapy first. 2 trials, one across the Atlantic, one from MD Anderson, showing that chemotherapy first, instead of chemoradiation first, is the way to go. We should prime the tumor with systemic chemotherapy. The same was showing over here. And induction chemotherapy remains the promised strategy, followed by chemoradiation in our own experience. And there's a set of retrospective analysis that suggests that chemotherapy first, followed by chemoradiation, has the best outcome, particularly in patients where you do not see any evidence of distant metastatic disease. You can see here in red that the chemo followed by chemoradiation therapy approach appears to have the edge. And regarding choosing the agent to pair with radiation therapy, it appears that the fluoropyrimidine here was done with capecitabine, appears to be a better radiosensitizer than gemcitabine. Here you have in blue that using capecitabine with chemoradiation appears to have the edge compared to gemcitabine with radiation, 15.2 months compared to 13.4 months. Now, the most comprehensive trial done to date has the fault of using what we believe is inferior chemotherapy in this DNA age for locally advanced pancreatic cancer. It was a 2-by-2 randomization, and it should be, unfortunately, analyzed at 2 different compartments just because of the nature of pancreatic cancer. You would expect that patients receiving chemotherapy first here in the first randomization would frequently fail with distant metastasis prior to receive radiation therapy. So if you analyze the trial as one study, you will be losing the role of a local approach because you wouldn't be selecting the patients that did not migrate to metastatic disease. So when the trial was initially presented at ASCO, it did not show any improvement in outcome. The trial was basically treating the patients with systemic chemotherapy, either with gemcitabine or gemcitabine and erlotinib here. And then in the second randomization, the patient would continue on the same chemotherapy they were on, and they were randomized to plus minus chemoradiation with capecitabine based on the data that I showed you that was felt to be the best radiosensitized agent to radiation compared to no chemoradiation. The patient would continue only with systemic chemotherapy on randomization number 2. So for the discussion today, I think this is the most important component of this 2-by-2 randomization, and that's intent to treat. That's basically chemotherapy or chemoradiation after being primed with chemotherapy. This is the survival curves of the entire study, including the first and the second randomization. And here, you don't see a row in survival. You do not see any benefit from the chemoradiation component because you're including the patients from the very beginning. And 1/3 of those patients progressed with distant metastasis. And if you use the intent to treat analysis, you would lose the role of a local control as benefiting this population of patients. And when we analyze from the second randomization, we start then to notice a potential benefit on chemoradiation by the site of progression. You can see that chemoradiation is doing what it's supposed to. This is only in the 236 patients that did not progress after the first randomization. And you can see here that the local control is improved. The progression in patients receiving local radiation had a net gain of about 14% compared to chemotherapy alone. You guys manage those patients with pancreatic cancer. I do not need to tell you how important it is local control in this disease. We're talking about gastric outlet syndrome. We're talking about pain. We're talking about nutrition. So those patients that received chemoradiation after randomization 2, they didn't have better local control, were better in the symptoms I just described to you. In addition to that, because of better control, not analyzing from the very randomization, analyzing from the second randomization, you can see here in red that there was an improvement in progression-free survival that almost reached statistical significance, 0.55. I mean, this means that there is a 5.5% chance that this result is by a chance only and it's not a true result. I'm happy with that. I think there is a clear role for this modality in local control in the selected patient population. If you only take the patients that had the treatment-free survival, not overall survival, not progression-free survival, because progression-free survival, you also add patients that die from the disease. You also add patients that come out of the trial for toxicity. But in patients that were kept on treatment and failed because of cancer progression, and cancer progression only, there was a clear benefit here, statistically significant, of the chemoradiation therapy arm compared to the chemotherapy arm. But again, we are far from doing well in this disease. So what are the strategies to improve outcome? What I do, personalized medicine, this is my area of study and academic focus. Also, improvement in systemic chemotherapy. Dr. Vu brilliantly presented to you that only about 12% of his series, or putting the series together, failed at the local tumor bed after IRE. So most of those patients fail with metastatic disease. And also, there is a chance to improve in local regional treatment, and that's where IRE and improvement in chemoradiation would play a role. Personalized medicine, I'm not going to bore you. I'm not going to go through this table. This is just to show you that I, among others, are working on getting clinical predictors and biologic targets in this disease. We're making some advances, but we're still far away from that. Improvement in systemic chemotherapy, we are basically transporting the success in metastatic pancreatic cancer with the new regimen into the locally advanced world, and this is with the combination of gemcitabine and nab-paclitaxel. The IMPACT trial, this is a metastatic disease, was superior to single-agent gemcitabine. The cooperative group system under the leadership of the radiation treatment oncology group is taking this randomized phase 2 trial in which we are basically stratifying patients according to the expression of SMAD4, that appears to be a predictor of outcome in pancreatic cancer, then treating all those patients with chemotherapy for 3 cycles. This is day 1, 8, and 15, every 28-day cycle of gemcitabine and paclitaxel, and then break them down according to, again, using capecitabine as a radiation sensitizer, whether it's standard 3D radiation, or with a new technology, very focused high-dose radiation therapy, up to 63 grade, that is tumor-specific in the bed, or to continue with systemic chemotherapy alone. The results of this trial is forthcoming at this ASCO 2016. With FOLFIRINOX, we, among others, have incorporated the results of the French trial that's showing improvement compared to gemcitabine. In that trial, there was an improvement of 11.1 months compared to 6.8 months in the gemcitabine arm. There was a major achievement with a 3-fold improvement in response rate. This is a regimen that has a response rate that is over 30%, and this is in metastatic disease. So this gives an opportunity to really bring in a regimen that can downstage a tumor or make it more palatable to surgery or even to the IRE, and priming the biology of the tumor, understanding if the patient will fail metastatic disease or not. This is a table of the FOLFIRINOX regimens, single institutions, done in locally advanced pancreatic cancer. This is our group when I was at the University of Miami. We treated 51 patients. And our median cycle here is probably in the higher numbers compared to other institutions. About half of our patients receive radiation, and those patients also receive IRE. And our resectability rate is here, is about 1/5 of the patients, and all those patients are locally advanced. I'm not talking about borderline resectable. We're talking about patients with locally advanced disease. We had one of the best median overall survivals. And our institution was the only one that routinely used IRE when primed by FOLFIRINOX. Again, when you go through all these other institution trials, again, it's comparing apple to oranges. What made the difference from our institution to the other trial was the routinely use of IRE together with radiation therapy, and also our number of cycles was, median was 8. And whenever we look at the number of cycles of chemotherapy, 12 or more, those patients did be because of their biology, did not fail with distant metastasis as frequent, they survived longer. However, we made one capital error, is that we did not prime with laparoscopy all our patients that went to IRE. So we learned from our mistakes, and we are routinely doing so in our institution. So the role of IRE should be discussed by champions that are on my right side. I'm a medical oncologist. I do not do the procedure. I sit down at tumor boards and discuss the patient that will go for IRE. I follow the patients post-IRE in my clinic. My experience with that is that it appears to be a better outcome in regard to time to treatment failure. It appears to be a better local control. Again, I see as a medical oncologist following those patients less difficulties with gastric outlet syndrome, less pain, but it will require a randomized trial to really tell us the impact in survival of a new modality, and IRE should not be different than any other modality. And I believe that the group from Norway, Dr. Martin, correct if I'm wrong, is leading a randomized international trial to look at the role of IRE in locally advanced pancreatic cancer. So in summary, in patients with borderline resectable, cure is still a goal, and surgery alone remains the only curative modality and should remain a goal. And we still need more randomized trials to best sequence the therapeutic modalities that we have. But here in our institution, we sequence chemotherapy, sometimes chemoradiation, plasma ions IRE, and the resectable patients going to surgery. Our zero resection rate is still the goal of the approach. And in locally advanced disease, retrospective data suggests that chemo followed by chemoradiation is superior than chemoradiation up front. FOLFIRINOX or gemcitabine nab-paclitaxel are the two regimens that, based on the results in metastatic disease, we incorporate into the local advanced world. The LAPO-7 trial, the most comprehensive local advanced trial done to date, suggests no benefit in survival, but a benefit in local control, in time to treatment failure, and in symptom improvement in patients that do not progress after chemotherapy. Should be a sequence with chemoradiation. And incorporation of IRE may lead to improved overall outcomes in locally advanced disease. At Gibbs, in the institution that I am now, we use the laparotomy approach for IRE. If a patient has unresectable disease, we treat the patients initially with FOLFIRINOX for 6 cycles, and there's 3 months of treatment, or gemcitabine and nab-paclitaxel for 3 cycles or 3 months of treatment. And we restage the patient. If it is still unresectable, we sequence them. And because surgical approach is the only approach we have in our institution right now, we prime them with chemoradiation, we sequence, not resectable yet, they go to a surgical procedure where they have a surgical IRE, even if they're not resectable. And again, in being an institution that recently started IRE, we already picked up patients with micrometastasis in the peritoneum. The procedure was still done because of improvement of local control, pain, gastric outlet syndrome. But here we're not looking for a cure attempt, since those patients already have metastatic disease when you get into by discovering into the laparotomy. If the patient has a response to resectable disease, surgery is then performed, and we follow that with a gemcitabine and capecitabine radiation post-operatively. If the patient progresses with distant metastasis, to proceed on palliative chemotherapy. Muito obrigado.